Well, that was a very tough act to follow, isn't it? So I'll do my very best. I'm Rob Franklin. I'm from Dudley CCG. For those who don't know Dudley, it's around 9 miles north of Birmingham. I'll do my best to remember my presentation. It's been a really sort of busy day, so I'm sure you can imagine that your headspace has almost gone like this throughout the day. So I've got it somewhere in there, but I'll have to try and find it as I go through. What I kind of wanted to talk about was around our journey as a CCG over the last 18 months. Now, when I kind of first started, I'm sure this is a report that you're all used to seeing. So it's our PALS data, our FFT data, our choices data, our patient opinion data, our real-time survey data, and lots of different data tables, which when I first saw it, I thought, that's really exciting. I've got all this information now. What can I do with it? I didn't really know. My manager came over and went, can you give me some assurance that actually the trust is performing well? And I went, well, OK, I'll have a look, but I'm not really too sure. The next day, we had this piece of feedback come up on Facebook, which was what a patient had put on with a piece of blood in one of the A&E cubicles. Now, forget all that data. That was the most important bit. So everybody suddenly jumped up, saw this piece of feedback, and it wasn't seen in the wider context of every single piece of data that we had. Now, that report, there must have been, for that quarter, about 9,000 patient stories. These are people's stories, their experience of care in one individual report. But instead, everything was kind of focused on this individual piece of feedback. So, in my sort of head, I started thinking about this picture, and looking at these two sort of areas, I kind of saw the patient as somewhere down on the beach, and as the CCG, as looking down on those patients and going, actually, look at all these individual bits of feedback, but all we can see is these data tables, and actually where we want to be is somewhere in the middle, really, to be able to kind of see what's happening on the ground, but also to be able to go right the way back up. And that's the same with the hospital, and that's why we're working so well together. As we said all day, the NHS has got lots and lots and lots of information, but we just don't tend to use it in the right way, and we don't always look at it in the right way. And I think that's a real problem that we have, and something that we all need to keep developing to progress. So I've kind of put this diagram on. My apologies for the guys who saw it this morning, but it just kind of lists a number of the different feedback sources that we've tried to triangulate and use together in Dudley over the last 18 months. Most of you are going to be familiar with these, your national surveys, patient opinion, friends and family test. For those that you can't see it, our version of the real-time survey, probably like your own, it tends to pick out the inpatient survey questions just so you can see over time exactly what's happening and try and have some sort of idea on what's going to come out in the inpatient survey, but that never really happens. NHS Choices, PALS, and also our My Experience real-time app. So actually what we found was just chucking all those together in a more systemised way could be quite useful. But the challenge we had was actually trying to find that similarity between all of the different data sets while trying to keep its individuality as well. So what we did do was go, actually, OK, if we look at one of our data sources, it's currently categorised in sort of the ad hoc way that it tends to be. So it's communication nurse, communication doctor, communication staff, communication receptionist, and actually all you want to know is that on a particular ward or a particular area, there's an issue around communication. You can drill it down and analyse it later, but actually you just want to find out what some of the big issues are that sit amongst all of those data sources. So that's what we did. We put in 12 subcategories that sit across about the 150 different categories that we have, so we can give some sort of level of insight. Now, sadly, you're not going to be able to see this on the screen, so it's exactly what Ben was saying around making things difficult to see. But this system here is available to clinicians so that they can click different elements of the picture and everything will change over time. So if they wanted to see what the negative feedback was by data source, so they can pick the data source, but if they don't want to, they haven't got to. But they can see if they click negative pieces of feedback, they can see all the areas in which they sit. Again, click of a button, they can see the wards in which they sit. Another click of the button, they can go right back down to the individual's comment on what they're talking about. Now, what's really valuable is if we're talking around things like food, around things like care and treatment, if we can see what people are saying on a ward level on a particular time, we can actually go, how can we make an improvement? The answer's there. If people are talking about food and drink, we've seen it time and time again. If we're looking at a particular ward, it will say Ward B4, there's negative comments around food and drink. OK, that's great. We've heard about negative food and drink lots of times. But actually, it's that on that particular ward, I wasn't offered a cup of tea. On that particular ward, by the time the food came out, it was cold. So it's around what small incremental improvements can we make that will make that massive difference to patient experience across the patch. Interestingly as well, little things here, like again we've been talking about all day, around technology, can again make a real difference to the patient. So we introduced a My Experience feedback app, really basic. Now, in terms of numbers of people that are using it, it's very small. However, we have had more feedback through this than through some of the national channels like Choices and Patient Opinion, so that's really positive. But what we've actually been able to do is use the data in a real-time way. So we had one example where an old gentleman had been sitting in the day case for about 8 hours, hadn't been offered a drink, hadn't been offered anything to eat, and actually a girl who was sitting in there with him noticed that this old man looked a little bit worse for wear. So actually put the app on her phone, messaged into us, who actually saw that piece of feedback, and somebody could go down, find that old man and offer him a drink, which I thought was really nice. And I know in terms of the global picture, it's individual things, but again, those little bits of information make the big difference. Again, linking in with how you present it, one of the things we've been doing is just kind of create a quarterly infographic. We share this with our chief exec. Again, as Ben was saying, the chief exec doesn't want every single individual bit of detail. They just kind of want to know what's going on across the trust this quarter. It's continuing developing. While I've been here today, someone's already given me a really good pointer on changing some of the text in it. So again, nothing stays still. We just keep developing and trying to make it better. Now, I suppose the next stage I want to talk around is our new models of care. So that sort of is happening in the background, but at the same time, Dudley is a Vanguard organisation. We're an MCP, so it's around looking at ways we can actually measure experience across a whole person's pathway of care. Because when a person uses the NHS, they may see their GP practice as their GP practice and the hospital as the hospital, but actually they tend to just see it as the whole NHS, one continuous system, and how can we kind of access that? So what we're trying to develop in Dudley is a system that kind of gives an expectation of a service or procedure. Now, a system that not only looks at a person's clinical aims, but also the ones that matter most to them. Now, I know we've got data like PROMs, but for lots of people, actually, some of those personal aims that they have, for example, in this gentleman's imaginary story, could be that he actually wants to run again. There's lots of examples of when people go in for procedures, and it might not be solely for the clinical outcomes. They could have personal ambitions and personal goals that they also want to achieve as well. Moving forward, if we can start to record those outcomes effectively and start to measure those effectively as a commissioner, we can begin to place value on those outcomes and start to use those to commission services. We've already started seeing experience by an individual, but we've never related an experience back to an individual's episode of care. Now, if we look at GP land, for any of you GPs in the room or know the sort of the GP world, GPs have had QoF for a long time. Now, QoF starts looking at an outcomes-based framework, and we've took that a step forward in Dudley with a long-term conditions framework, which is almost a side step to QoF. Now, what that does is one of the indicators within the long-term condition framework is ask a patient when they go in to manage their long-term conditions, what is the long-term, what is the outcome you want from your long-term condition? Is it around managing your diabetes better? Is it around X? Is it around Y? And actually reviewing that in 6-12 months' time to see what that person's outcome is and seeing the change over time. Now, we've already started using that. Some quotes on here from staff. It's really positive, and we know from speaking with patients as well, it's making a really big impact. One of the things we've kind of talked about today as well is that healthcare doesn't kind of operate in isolation. There's lots and lots of different elements of the whole system, really, that can actually impact a person's health. So we're doing a piece of work with an organisation called SciAMS around looking at a person's personal social impact assessment measurement systems. So that's basically around looking at their economic factors, around their social factors. So if someone's depressed, actually what is it that they need to stop being depressed? And that's quite a big piece of work that we're operating on. We know in terms of the system, there's lots of barriers. As a CCG, trying to hold patient-level data is really challenging. We know that, as a CCG, trying to get the trust to buy in with a whole system shift can be really challenging. But we just feel that actually if we can get individuals to own their own data and to manage their own data, we'll hopefully be able to improve patient experience and make it better for the patient. I've hopefully run through that really quickly, so I've managed to save some time across the day. I hope that all made sense. But if you've got any questions, I'll be about all day, so just come and grab me. Thank you very much. Yeah.